Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for extract 1.
Extract 1. Questions 1 to 12.
You now have 30 seconds to look at the notes.
Hello, Gary. I'm Dr. Hamilton. Nice to see you.
Nice to see you, Dr. Hamilton.
Yeah. Your doctor had called me. I've got your notes from him.
Yeah, I've been trying to reach you for the last 2 months, actually.
Right.
I've been having a few issues, and I went to my GP, and he asked me to come and see you.
Yeah, that's right.
You're a very busy man indeed.
Indeed, absolutely. Yeah, and I've been traveling for a while as well. That's right. Yeah, so I've gone through your notes.
Yeah.
And I've seen that you have been in trouble for quite some time.
Yeah, I mean, clearly for the last 5 years, I've been having tummy pains a lot.
Okay.
And the last sort of a month, it's been more and more. Long before that, the last 6 months, it's been tough. But the worst in the last 1 month.
All right.
And I've been trying bits and pieces, but it hasn't helped me a lot. So.
Okay. All right. Yeah. So I know that your doctor had prescribed some antacids and things like that.
Yeah.
Yeah. But now we have reached a stage where we'll have to run a couple of tests.
Yeah,
right.
More than happy.
Has the doctor discussed that with you?
He roughly mentioned that I need some blood tests and everything.
Yep.
And possibly, if things are worse, he said I might need an endoscopy.
That's right, absolutely, yeah, indeed, yes.
So I'm ready for any sort of surprises.
Okay. Given that, you have this problem, particularly when you have food, I suppose.
Yeah, well, after I eat, to be precise. So.
Right.
But if I skip a meal or something, I can get it. But every time I eat something, basically acidic, if I take anything acidic, any fruit juices or anything, or if I take anything spicy, I get it as well. So.
Okay. So can you let me know in detail what you feel and where you feel the pain exactly?
Well, I feel it on the lower part of my tummy.
Okay.
And exactly, it's sort of like, how do I put it together? It's a stabbing pain. I feel like I've swallowed a knife and it's like stabbing inside my tummy. That's exactly how I feel when I have food.
Okay.
Well, if I skip a meal, it's slightly different. I feel like a burning sensation inside my tummy. I feel like something's not right and something's on fire. So.
Okay.
Yeah.
So does that affect your work?
Very much, yes. I had to call in sick a few times, And when I have sharp pain, I can't concentrate on my work.
All right, yeah.
Yeah.
So, do you take any pain medication for that?
Well, I do take paracetamol every now and then.
All right.
And I take some ibuprofen when I have pain.
Okay.
I have tried some antacids.
Right. Did that help?
Well, yes and no. If it's the burning sensation, it helps. But if it's more of that stabbing pain, it doesn't help very much. I have to wait for a long time for this pain to settle.
All right. Can I know a little bit more about your diet?
Well,
What do you typically have for, say, breakfast, lunch, and dinner?
yeah, well, my schedules at work changes every week, so I don't have any set times to eat. So my breakfast could be 7 in the morning in 1 week and probably 9 in the morning the next week, and probably the third week I might have to skip my breakfast. It's all for, work purposes. Same as lunch, no specific times. In
What do you
terms of,
generally have?
in the morning I might probably sometimes just have a cup of coffee, that's it, and no breakfast or eat. And at lunchtime I try to grab something from outside. Mostly takeaway food.
Okay.
I've got a Chinese takeaway right next to my work. I try that. I've got a few burger places,
Okay.
and might try some KFC burgers every now and then. So since I don't get much time to make this food at home,
I'd like to know what your thoughts are of, what you're going through. Have you got any idea what it could be?
I haven't pinpointed on anything.
Okay.
The doctor said I could have things like gastritis or, worst case scenario, he said I might have issues with the lining of my
It seems very likely to me. Yeah,
Yeah.
that's right. Yes.
and
However, I can't confirm it at this point of time.
I understand that.
So you'll be having a couple of tests
Yeah,
by next week.
yeah,
So first we'll go for some blood tests.
okay.
All right. Yeah, and then
Today or should I come back next week?
on your way out, you can give your blood samples,
Okay,
and I'll schedule an endoscopy for you.
okay,
That should be in a few days' time.
okay,
And once I get the reports,
yeah.
I'll see you next week.
See, will you be doing the endoscopy?
I'll be there.
Yeah.
I'll be there. Yeah.
Yeah, cool.
Right. Yeah. And do you know what it is?
Well, I think it's like showing down tube down through my throat.
That's
yeah.
right. That's right. Yeah.
It's got a camera at the end. And
That's absolutely right. Yeah.
so you're going through the front end or the rear
The
end?
front end.
Yeah.
Yeah.
Yeah, I'm not a great fan of the rear end.
Yeah, that's called colonoscopy. That's
Okay,
definitely
cool.
right. Yeah, and this is slightly uncomfortable, but we'll numb you.
Yeah,
Yeah, we'll spray
yeah.
something to numb you, so that reduces the discomfort. And yeah, it's fine. Yeah.
Okay.
Right. Any questions?
Not very much.
Extract 2. Questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
So tell me what it is that bothers you about your skin.
I'm starting to get some crow's feet here, and obviously I'm trying to hide the age a little bit. So along with the fact that I have some wrinkles here, that it seems, whenever I smile or frown, I'm tending to get these wrinkles, but it's the fact that they're still a little bit permanent right now. Even when I'm not making any expressions, I still see the residuals of that. So I kind of want to make those disappear.
Perfect.
Plus, whenever I smile, I feel like these crow's feet tend to make my eyes look a little bit smaller.
Sure.
So along with the fact that, even when I'm smiling from here, I'd like to have a little bit more lift.
Okay.
So whatever it is that we can do to fix that.
Sure, absolutely. What you're noticing when you smile, there's a muscle that goes around your eyes here that squinches when you smile, and that gives you the lines that are perpendicular to that muscle. But it also closes your eye a little bit because it forces the downward motion of your eyebrow, which is also kind of closing down the outer portion of your eye. We can actually use Dysport, which is a medication that helps to relax the muscles so that when you smile, the muscle won't squinch here.
Okay.
That'll actually keep your eye open when you smile, which I think you'll like. It'll make you have a wider-eyed appearance. It'll also lift your lateral portion of your brow up a little bit if we treat this area. It's done with 3 simple injections on either side of the eye into that muscle. It doesn't really hurt much. It's a little tiny pinch.
Mm-hmm.
The medication usually takes between 3 to 5 days to set in and work, so you won't see immediate results today, but you should notice something by a week from now. If you were to still feel that it was moving in a week from now, come on back in, let me take a peek at it since it's the first time you're having this done, and I can let you know if the muscle needs a little bit more of the medication. That medication, the Dysport, then lasts for about 3 to 4 months in most people, but during that time when you're not able to crunch the skin, your skin's always making collagen and it's always being broken down, and if you're not able to scrunch the skin up from the muscle action, it won't get those deep lines in it, so you can make more collagen to even fill in those lines that you're starting to see at rest. So there's a bit of prevention with using the Dysport around the crow's feet to prevent them from getting deeper. Same thing with your forehead. It's a different set of muscles that helps to lift up your brow. Now, because I need your brows to still lift a little bit, we don't want to leave them lying flat because then I think you're going to feel that your upper eyelid feels too heavy. So what we can do is we can treat your forehead muscles, the frontalis muscles here and here, with a little bit of the Dysport, but we'll still allow you to have some movement. Men usually don't like to have a frozen look. They want to have some animation with their eyebrows, but I can give you a lighter treatment so that you can still move your brows, but you won't have the deep crevices in the skin when you do that. And again, by letting the muscle relax, the skin will then start to fill in collagen and fill in those lines so you don't see those lines at rest. It may take more than one treatment with the Dysport for that to occur because it takes several months to build up collagen, but over the course of a year or a year and a half, you should virtually see those lines disappear. If you were someone who had much deeper lines, it might take more like 2 or 3 years for that to occur, but since your lines are very fine, I don't think you're going to have any problem with having them improved with even just one treatment.
Sounds great. From pictures, I'm tending to see my eyes always a little bit on the squinchy side. So
small, yeah.
This sounds excellent. Is there anything I have to do after the injections?
It's a great question. So what we ask you to do is to move the muscles to work the medication into the nerves that drive the muscle action. So all that would entail is lifting up your eyebrows a few times in the next hour and a half or so. You don't have to do it all day long. You don't have to do it for 4 hours. If you did it 5 times in the next hour and a half, that's probably plenty. And then also smiling so that you can squint the side muscles on your eyes as well for the next hour and a half. Other than that, the only thing we ask you not to do is have a facial massage today because we don't want the medication to be moved to any other muscles in the area. But you could work out, you could do yoga, you can do anything you normally would do except for having a facial massage for the next 10 hours. You can lie down, you can take a nap, any of those things are fine.
Simple enough. I think I can abide by those rules.
Great. Do you have any other questions at all?
That's it. Thank you very much.
Then we'll get started.
All right. Excellent.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Now read the question.
It's quite unfortunate that the patient died. When it comes to pulseless electrical activity, we have less than 3% chance to get them back. He had a lot of comorbidity, so we need to talk to each other about it. The reason why I'm talking to you is that this shouldn't get to us. We're professionals. We have to talk to each other about it. This shouldn't stress us out. It shouldn't bring our confidence level down. We have pastoral care services. If you need to chat to them, you can speak to me as a manager. I can help you with some tips and tricks, because this is not the last arrest you're going to face. There are going to be more. On top of everything, it's a huge learning curve. After every arrest, we need to have such a debrief, so everyone would feel comfortable. I thank everybody for your support. He had a lot of comorbidities, as I said. We need to focus on the things where we need to concentrate. Little bits and pieces. Everything is very important, and a couple of people I want to speak separately about life support. How traumatic it can be, and I saw a few tears. It's all a part of this. Over the last few years, I've lost patients, and I have got some of them back as well. So it's very much an important thing. But we'll speak about it later. But feel free to come and speak to me if you need any help.
Question 26. Now read the question.
The problem of failed teamwork has been identified in both practice and literature. As a nurse manager, I witnessed the power of high-performing teams and also noted the effect that pitfalls in teamwork can have on outcomes. Nursing literature informs us that nursing teamwork has been discussed for many decades, yet is still difficult to achieve. We also know that failures in teamwork can result in poor patient outcomes, patient complications, increased length of stay, and patient mortality. The statement of the problem for this research is that preventable patient safety incidents continue to be expensive on national, organizational, and personal levels. For example, pressure ulcers, a key nurse-sensitive indicator, can result in approximately $50,000 of additional costs to a single hospital stay. In addition, 60,000 patients die as a result of pressure ulcers each year, and pressure ulcers are the second most common litigation claim, second only to wrongful death. Transformational teamwork exists when a transformational leader influences not only individual followers, but also influences the team as a whole to perform optimally, resulting in high-quality outcomes. Transformational teams demonstrate quality teamwork, resulting in high performance and quality outcome indicators, and the work of the team transforms care to a higher level of performance.
Question 27. Now read the question.
We set a comfort goal for 3. What's your pain level at right now, Mrs. Craig? On a scale of 0 to 10, how do you feel?
About a 7.
About a 7. Okay. She's on a liquid diet.
Is she taking anything for the pain?
She is. She has ordered 0.5 milligrams of Dilaudid IV as needed every 2 hours. And she did receive that about 6:30. I updated the boards. The next one due, Mrs. Craig, would be about 8:30 this evening. She's also been using splinting, which has helped with the abdominal pain. She's on a clear liquid diet with orders to progress to a regular diet as tolerated. She also has orders to start oral meds as soon as her diet can be advanced, which might help out with some of the pain issues.
So part of my plan of care for you today is going to be making sure that your pain is controlled. You indicated that it was at a 7, and you're not due to have more pain medication until 8:30. And so what I'm going to do is I'm going to go back and I'm going to check to see if there's anything the doctor has ordered for you that we might be able to give you in addition to the Dilaudid that you're already receiving. Many times physicians will order different kinds of pain medications that patients can take concurrently. I'm glad that you're splinting using the pillow to press down when you're coughing or sneezing. That also helps with pain control. Now, another non-pharmaceutical way to control pain, help alleviate it, is actually activity. It might seem counterintuitive, but making sure that your body is moving and that you're using your muscles actively helps control the pain. So if possible, I'd like to get you up this evening. Maybe if nothing else, just walk to the bathroom or maybe walk to the door and then back again. I think that might help your pain, provided it doesn't make it excruciatingly worse, okay? Does that sound like a plan?
Question 28. Now read the question.
We know from all the research we've done on animal behavior and that sort of thing that natural light is huge in terms of keeping the animals calm, less stress. It's a nice factor for us and our staff when we're inside a building that has good natural light throughout. Usually the treatment area is kind of right in the core of the hospital in the middle. It may have some windows, but not a lot. And that's one of the biggest areas where having natural light is a huge benefit. So how do we get natural light in there? Depending on the design and structure of your building, using clear story windows that are up high, that can, allow the natural light to penetrate down. That's an easy way. Not always possible if you're in a lease space or a tenant improvement space that you're building out, then you're at the mercy of what building you're stuck with. So other ways to deal with this. Skylights are a great way. You have to have a flat roof usually to be able to do that. Pitched roof you can, but there's products like out there called solitubes, which are like a skylight, but they are made to work such that they're just a little diffuser up on the rooftop, and they bounce light down through a metallic tube to what often looks like a light just placed in your grid ceiling, but it's the right color temperature light because it is the natural sunlight coming into the space. We've also seen a trend towards people wanting more transparency in the hospital just in terms of their relationship with their clientele. And so using windows through exam rooms, and then that potentially even lead back to treatment. It's kind of a newer concept. Some people love it, some people hate it, but having more windows up front in your exam rooms and potentially passing through to treatment is another way you can get light back into the back of the hospital.
Question 29. Now read the question.
Clopidogrel reduces platelets' ability to form blood clots and is usually used with aspirin. There are several reasons for taking clopidogrel. The commonest is after a coronary artery stent to stop the stent causing a clot. Another is after a heart attack or serious chest pain to prevent a recurrence. One of the risks with aspirin and clopidogrel is a stomach bleed, so some people are also put on an acid-lowering drug called a proton pump inhibitor, a PPI. PPI's names end in azole, like omeprazole. It's the combination of clopidogrel and a PPI that's been questioned in a study following 8,000 people who'd been given clopidogrel after experiencing a heart attack or pre-heart attack chest pain. People taking both clopidogrel and a PPI were a bit more likely to go back into hospital or die from another heart event than those just on clopidogrel. Mind you, people on the combination were older and sicker than those on clopidogrel alone, but even allowing for that, the worst outcomes persisted. PPIs may reduce clopidogrel's antiplatelet effect and therefore increase artery blockages. Now, there are many reasons this study could be wrong, so further work needs to be done. But if you're on the combo and are concerned, have a chat to your GP about it.
Question 30. Now read the question.
So tonight I was talking about how one patient drives the need for research and how the problems that those patients present, however simple, can sometimes be really difficult to solve unless you're working with a team of researchers in the background to develop new ways of doing things, and how by growing a trachea in the lab from a group of donor cells, we were able to change a child's life. First of all, the plumbing part of surgery is obviously what we do every day. But to move it on to the next stage, to solve the problems that constantly come to Great Ormond Street, you need research, because it's the new ways of doing things that continually allow us to offer these children some sort of chance, some hope of a better life in the future. And without the close relationship of research and scientists with the doctors and the patients on the ward, you don't make those big steps forward that you need to do.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
I'm joined by Dr. Robin Steinhorn from Children's National, and we're here to discuss her talk on BPD-associated pulmonary hypertension. Welcome, Dr. Steinhorn.
Thank you.
Thank you so much for being here. Can you tell us what was the main objective of your talk?
Well, I think in my talk, with the brief time I had, was to increase awareness of how common pulmonary hypertension is in preterm babies, both early, in those babies that have severe hypoxemic respiratory failure, and later on associated with their bronchopulmonary dysplasia.
To follow up, how common is it in these preterm babies?
So in preterm babies, about 2% of them will have significant pulmonary hypertension in the first week of life, some so significant that it is life-threatening, and detecting it and treating it can be life-saving. More commonly, though, we see pulmonary hypertension associated with bronchopulmonary dysplasia when it's diagnosed at 36 weeks postmenstrual age. And in that population, in particular those babies that have moderate or severe BPD, we'll see pulmonary hypertension in anywhere from 10 to 40% of those infants.
How would you say is the best way to detect this pulmonary hypertension in the early onset group, these preemies who get it early?
So the answer would be the same for both groups, and I think it would be two things. First is being aware that this condition exists, and because you're not going to find what you don't look for, the best way to screen is with a cardiac echo. Now you have to really work with your cardiology team because pulmonary hypertension can be diagnosed with a tricuspid regurgitant jet, sort of that traditional way, but there are other more subtle signs. Septal flattening, right ventricular hypertrophy, right ventricular dilation can also be signs of pulmonary hypertension. This early group can also be important because what Pete Morani and Steve Abman have showed us is that if we see pulmonary hypertension, even these subtle signs in that first week of life, it's a powerful predictor of later lung disease and later pulmonary hypertension.
And if we diagnose pulmonary hypertension in these preemie babies, in your opinion, what's the best way to treat this pulmonary hypertension?
Great question, and one that we really don't have good answers for. In the first few days of life, if you have a preterm baby who doesn't have much parenchymal lung disease, or you've treated it and the lung looks fine, and that baby still has life-threatening hypoxemia, our recommendation would be to give a brief course of inhaled nitric oxide. We know that 90% of the babies will respond with an improvement in oxygenation, and survival is about 80% in what is clearly a very high-risk, very ill population. What we don't really know is later on in that child who has BPD-associated pulmonary hypertension, what is the best course of treatment. We do recommend considering treatment for babies who have significant pH, so pulmonary arterial pressure that is more than half, often more than 2/3 systemic, starting with monotherapy. Sildenafil, bosentan tend to be the two most common choices. But what we don't know is the length of therapy, and none of this has been optimized yet through randomized trials.
That's true. What would you say, Dr. Steinhorn, is the overall main point that you would like the audience to take away from your talk?
So I think there's a couple of points, is to tune your eye to the possibility of pulmonary hypertension. The preterm lung is disrupted not only in its parenchymal development, but in its vascular development as well. And so this is a very high-risk population. I think to consider pulmonary hypertension as a cause of hypoxemia, both early and late. And third, to remember this is a team sport. That in particular, these children with severe BPD, you're going to need a team that is very expert, not only in the lung support, but the pulmonary vascular support. So a cardiologist, ideally one that has expertise in pulmonary hypertension.
That's great. And how about, I know there's a lot we don't know about pulmonary hypertension in the preemie population, so where do we go from here?
Well, my hope is that increased awareness will inspire our community to come together and do the trials we most need. To me, it's pretty shocking that of all the drugs that are available for pulmonary hypertension, only one is approved in children at all, and that's bosentan. So developing that evidence base for what drugs we should use and when for children who clearly are at high risk, I think that's a really important problem to solve, and I hope the neonatologists here will participate in trials when they begin.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
We've been studying a disorder called seasonal affective disorder. Norman Rosenthal first identified this disorder in the mid-'80s. The theory is that a decrease in light during the long winter months may be responsible for triggering a chemical imbalance that in turn may cause depression among those people with a predisposition to depression. Supposedly there's an area of the brain called the suprachiasmatic nucleus, which is very close to the retina of the eye. So this area of the brain responds to light by sending a signal to the pineal gland, and the signal causes the gland to suppress the secretion of a hormone called melatonin. To make a long story short, the more light, the less melatonin in the blood. Okay, the acronym for seasonal affective disorder that's being used in the field is SAD. We didn't come up with that. And in fact, I personally think that it's an inappropriate way to refer to such a serious type of depression, since it sounds rather mild, and seasonal affective disorder can be a very severe and debilitating disorder for some people. In fact, in extreme cases, it's life-threatening when patients become suicidal. So anyway, as you can appreciate, the winter here is very dark, cold, and gray. By spring, almost everyone's tired of the gloom, but for some people, those suffering with seasonal affective disorder, it can be a serious problem. People with seasonal affective disorder experience deep and prolonged depression throughout the winter months, with what looks like a spontaneous alleviation of the condition when spring arrives. Before the disorder was identified, it was rather a mystery for friends and family, since the depression appeared to vanish only to return several months later. Now, although previous research isn't conclusive, we do know that younger people, especially younger women, these women are at a higher risk for developing the disorder and for being affected by it in a more severe form. If I recall, about 75% of those affected are women, with a typical age of onset about 30 years old. Other factors that contribute to the problem, apart from the long dark days, of course, these factors include heredity and stress. What are the symptoms? Well, the usual spectrum of problems associated with depression: anxiety, lack of concentration, a tendency to sleep more and eat more, cravings for food with a high sugar content. This may be accompanied by weight gain. On the other hand, some people actually lose their appetites and tend to lose a significant amount of weight. We also see lower energy levels, and for some people, a dull headache may accompany the problem. So, building on the research studies that identified the symptoms of seasonal affective disorder and the high-risk profile, we decided to undertake a longitudinal study of 120 subjects, and our research is really focusing on therapies that might help those people affected by SAD. Traditionally, psychotherapy has been used to identify and modify behaviors that contribute to depression, and it's been somewhat successful with patients identified with seasonal affective disorder, especially when used in combination with relaxation and stress reduction therapies. Antidepressant drug therapy has also been proven to reduce depression in studies of people who had seasonal disorders. But we've been using phototherapy almost exclusively with the subjects in our studies. It's very simple, really. We've supplied each subject with a light box that provides the same type of natural lighting that would normally be shining through the window during the spring and summer. The subjects have been instructed to turn on the light box for 2 hours and then simply go about their activities in the room where the box is placed. They're not supposed to use the box like a sun lamp, no staring into the light, either with the eyes closed or open. They just ignore it once it's turned on. So, although we're still evaluating our data from the first group of subjects, we have a few preliminary findings that I'll share with you today. First, we think that it's probably better to be exposed to the light box during the morning hours. Second, we're noticing a relationship between sleep patterns and seasonal depression, so maintaining a regular schedule for sleep seems to be a helpful therapy in conjunction with a light treatment. We're also fairly sure that the duration of light therapy can be modified for individuals. Some subjects who were exposed to the light for less than 2 hours did very well, while others showed no evidence of relief until they reestablished the 2-hour treatments. One interesting possibility that we're working on is whether fluorescent lights might work as well as full-spectrum light with the ultraviolet rays filtered out. In our first trials, we used UV light exclusively, but now we have some trials underway with fluorescent light, and the results so far are encouraging. I'm also happy to report that there are few subjects who are experiencing side effects. There's no evidence of eye damage. We've been careful to filter out any potentially damaging UV rays. And in fact, the only negative side effect was minor headache that seemed to disappear after a few treatments. So, next semester, we plan to begin the second stage of our studies, and we'll be comparing the degree of depression on the part of subjects undergoing light treatments with control groups who'll receive either drug treatments or psychotherapy. What we really want to know is whether light treatments alone are as effective as the other options for therapy.
That is the end of Part C. You now have 2 minutes to check your answers.